Okay, so I'm going to be talking about evidence-based psychosocial practices for inpatient child psychiatric settings. And before I get into my talk, I wanted to get a sense from you all who are working in these settings, what is the biggest challenge you are having in terms of implementing any evidence-based psychosocial interventions, either on a milieu basis or a client-specific basis in your settings? What are the biggest challenges that you are experiencing in doing that in your settings? As we move forward today, it's important to think about one of these challenges that you feel that you can actually make a difference in that area, because there's a tendency when you kind of identify challenges to get overwhelmed that there's so many, or like the family problems are so pervasive, to think that, well, there's not, like, I can't do anything about this, and then you get stuck and discouraged about making change. So as you're hearing about these different approaches, think about what's something that you could do, what's feasible for you, what's an area that you can actually make a difference in. So I just want to place evidence-based practices in context a little bit, particularly for inpatient settings. So when you think about evidence-based practice from a research perspective, there's a pretty stringent kind of gold standard to meet in order for any particular practice to be characterized as evidence-based. And listed on this slide are the different criteria that are involved in making that determination. So it's really about having a controlled group design studies with different investigators, a manual, looking at the adherence of the clinician to the particular treatment, and then long-term outcomes that go beyond when the treatment ends. That's kind of the top notch in terms of defining anything as evidence-based. But if you think about your own settings or residential settings in general, it's pretty difficult to meet all of those standards because of some of the things that are listed here. So in any inpatient setting, you have multiple interactions with different providers. There's this, staff are changing across different shifts. There's program variability. So all of these things would make it really difficult to have a controlled study in any type of inpatient setting. That's not to say then that you can't do evidence-based practice in inpatient. It's just that you have to think about whether or not you can meet that gold standard. And the fact is that you can do evidence-based practice without necessarily meeting that gold standard. And these are some other approaches to evidence-based practices that are important to think about and consider, particularly for your settings. So one is the common elements approach that was developed by Bruce Tripita. And the idea behind that is that in any kind of treatment, you can distill what's the common element that really makes the difference in terms of outcomes. So for example, in cognitive behavioral therapy for anxiety, it's been found that the common element or the key factor is exposure. So if you don't do exposure in whatever anxiety treatment that you are using, you're probably not going to get the types of outcomes that lead to improvement in the child's behavior. So you don't necessarily have to stick to a complete treatment manual for anxiety, but you have to make sure that you have that key component. It's kind of like if you like to cook, which I do, you can let's think about bread. There are lots of different types of breads that you can make, different recipes, but if you don't have yeast, it's not going to be bread. So it's the same with the common elements approach. It's kind of thinking about what's that key component that makes the difference in terms of the outcomes for the child. The other thing to think about is practice-based evidence. And all of you that are working in the SIPPs have practice-based evidence. You know in your setting what works. And when you think about what works from a practice-based evidence perspective, it's not just about saying, well, I like to do it this way and I think it works. It's actually having proof that the practice that you're using is working. So collecting some type of outcome data through a questionnaire or self-report that indicates that the practice that you're using in your facility is making a difference. And the same goes with the case-specific evidence. So for a particular child or particular family, you have evidence that whatever is being done works, but again, you want to make sure that the evidence is some sort of objective measure, not just the clinician saying, well, they come every week, I talk to them, and it works, and they seem to be getting better. But do you have proof of that? Because we all get kind of stuck in our ways and believe that what we're doing is helping, but if we don't have any objective measure to demonstrate that, it's not case-specific evidence and it's not practice-based evidence. So the real take-home message for this is, in terms of implementing evidence-based practices in inpatient settings or any settings, you really want to integrate what the research says, so what's the gold standard from a research perspective about what works, and then integrate these other things in terms of common elements, practice-based evidence, and case-specific evidence to kind of come up with a way of doing it in your own particular setting. So in terms of specific evidence-based practices, as I mentioned before, you really can categorize them into milieu-wide approaches versus client-specific. So I'll be talking about both of those, starting off with the milieu. And these are the 4 different ones that I'll speak about today. And I imagine that many of you have experience with these different approaches. So I'm starting off with behavior management because that's probably the most common milieu-wide approach that inpatient and residential facilities use. But oftentimes, the way that the behavior management is implemented is not what we would consider evidence-based. So just because you're doing behavior management doesn't necessarily mean you're doing it in a way that's effective. There's a lot of research to support the behavior management. I mean, it's probably one of the most widely supported approaches, both from an individual perspective in terms of children who have oppositional defiant disorder or conduct disorder, but the components of it also have been used on a setting-wide basis as well. And this just are some of the key programs. Parent management, of course, is big. Coping power, parent-child interaction therapy, and problem-solving skills training. Those are some of the specific programs that have a lot of research to support them. But more generally, behavior management approaches are based on some key principles of behavior that I'm not going to spend a lot of time on. You have this in your slide packet, but positive reinforcement, response cost, and timeout are some of the big principles that underlie behavior management approaches. And kind of reminding yourself what these are is also important, because they're so much part of what we say, but do we really know what it means? Now, of course, part of behavior management is consequences, and there are different types of consequences. So there are applied consequences like points or tokens, and natural consequences like activities, social praise, or attention. And then these are kind of the key characteristics of effective consequences. And again, thinking about how consequences are used on your unit, you can go back and decide, are the consequences on your unit, do they meet these criteria? So individualized, that's a really tough one, because usually on units, everybody gets the same points. It's kind of across the board. But do the points mean anything for that particular child? I see patients privately, and I was meeting with a child who has a lot of behavior problems and goes to a special camp that has a level system and everything. And he came into a session and was like, well, he can earn the maximum of 20 points a day. And he's like, well, I only earned 5 today. And I was like, oh, how do you feel about that? He's like, well, I knew I couldn't earn 20, so I just earned 5. And that, he didn't care. It didn't really make a difference. He'd already sort of decided that he couldn't earn the maximum amount. He knew that he couldn't earn enough points that week to get the prize that he wanted. So those points were not, that consequence was not individualized enough for him to make a difference in terms of his behavior. Proportional to whatever the behavior is, immediate, contingent, and then resisting satiation. That's really hard to do. So these are some specific behavior management techniques that incorporate the different principles that we just talked about. And I just want to spend a few minutes helping you to think about your units and to what extent you're doing these or what challenges you're having. So these are the questions. I'm going to flash back to the techniques, but I want you to think about which techniques are the most difficult for your unit to implement and why. Which ones have you actually been able to implement and kind of what's factored into that? And then which one would you like to implement the most? So those are the questions, and you can look in your slides in terms of the specific techniques. I just want you to spend a minute or so thinking about that, and then I'll ask for your responses from a few people.
Which ones have you been able to implement?
1 minute.
One more minute.
Ignoring. Look at that consistently.
Just like the opera.
Okay, so we asked everybody to write up their responses. So take a look around the room at the, what do you see as most difficult? We have ignoring over here, reinforcement, and positive attending. So ignoring is a big one. And then what people have been able to implement following the training for this table here, what did you?
Work program. What did you share?
So that was, so this, in your one, it was that you were actually able to follow through in terms of training, but the other issue is that sometimes you can't do that. Got it. And so this group back here said what you're able to do is identifying behaviors that are.
We went back and forth.
Okay. And the table in the back, it was positive attending and selective use of punishment that's something that staff can do. So thinking, and then I'm just, in terms of which ones would you most like to implement, here it's motivation, reinforcement, and praise. Here it was identifying individual, what did you mean? Individual behaviors, got it. Shaping for this table back here. Got it. So this is something to kind of, it's sort of a take-home for you all at your units to think about this when you go back to decide, just in terms of the behavior management, what are some things that you want to do more of? And we'll get towards how to get to that point later on, but this is just an important thing to think about. A couple more things in terms, so some of you already talked about motivation systems in terms of behavior management, and this is really, the goal of the motivation system, of course, is to increase the appropriate behavior, decrease the problem behavior, but the last thing is to teach a replacement behavior. So if you don't do that, you're not going to get very far. We often focus on the first 2 points when you're thinking about motivation without the teaching piece, and that's a key component. And then the last thing in terms of doing motivation systems in inpatient settings, you really want to kind of start with the least restrictive and then move your way up the ladder, because you're trying to avoid things that are likely to set the child off for very challenging and oftentimes aggressive behavior. And it goes to the point that you were mentioning before around kind of building a relationship with the child, so that reassurance, that rapport, that goes a long way in trying to minimize the chances that the child is going to escalate to a point where you need to restrain him, seclude him, PRN medication. So that's behavior management. We could spend the whole day on behavior management alone, but we're going to move on to the next intervention, which is collaborative problem solving.